I
Okay,
think,
we are live.
yeah. I welcome everyone to this 87th Masterclass. And this series is on Mullerian tract anomalies. And this is the third class on Mullerian anomalies. I hope everybody has watched the previous two classes because it gives you a lot of basic information and also about the practical aspects as to how to deal with Mullerian anomalies, which many gynecologists find it difficult to evaluate. And I know this because I have spoken to at least like 50 or 60 gynecologists when they refer their MRKH or when they refer Mullerian anomaly cases to be operated by Dr. J at Bangalore. And we have successfully completed more than 25 cases with excellent outcomes in Mullerian anomalies. And he has immense experience because he runs a charitable surgical the program for dedicated to Mullerian anomalies, and in that I think he has done more than 70 cases in this year. So over to you, Dr. Jay. You can take.
Yeah. So I'm starting with the screen. I'm starting with the screen sharing, and today we will be discussing fertility in non-obstructive anomalies. Okay. So yes, last class we discussed fertility in obstructive anomalies. Today we will discuss it in non-obstructive anomalies. In order to understand this, you need to really understand one important concept. You have two paramesonephric ducts who in the process of migration are going to come down and they are going to come close to each other. All right. When these guys come close to each other, okay, what happens is something like this. See this. Okay, and there are two vaginas like this. Okay. So what happens is there is a process of something called as differential canalization. Some parts will begin to canalize here, some parts will canalize here, something will canalize here, like this, like this, like this, like this. It will all continue to canalize. And first, it will form a cavity inside because of canalization. Of course, this cavity is the cervix. This is joint here. This is connected through the cervix to there, which have also got canalized, and then this layer in between, no, it begins to get absorbed. This whole thing begins to get absorbed. So if you look at this in the form of a 3D cylinder, okay, the final picture initially is going to be something like this with a single vagina. All right. And then what typically happens is the musculature here. So I will just draw the endometrium because this is the concept. Okay. See these muscles here, no? This muscle, this muscle, full muscle is there. Okay. Can you see these muscles are coming very close to each other here? All right. Now, when you have these muscles, then they also begin to canalize and fuse. So what happens? This gives rise to formation of three non-obstructive anomalies. Okay, and these three non-obstructive anomalies are very simple. One is arcuate uterus, third is bicornuate uterus. Okay, let me just draw each one of them. So one is going to be when they don't canalize at all, and in the process of growth, as the fetus keeps on growing, okay, the lateral pelvic wall will start growing. As the lateral pelvic wall starts growing, there is a development of endopelvic fascia, and the endopelvic fascia, simply due to the ability of collagen and elastin, will pull these structures towards the lateral pelvic wall, which will cause them to separate, give rise to formation of a simple bicornuate uterus. This technique and this picture, this entire picture also explains to you all the variations of bicornuate uterus with cervix. You can have bicornuate uterus unicollis, single cervix. You can have bicornuate uterus with two cervix, bicornuate, bicollis. This part has got absorbed because it is simple. There is a region of differential canalization and differential absorption. You can have bicornuate unicollis, bivaginalis, that is also fine. Vagina का part absorption में भूल गया. You can have bicornuate uterus, bicollis and univaginalis. That is also common. This part got canalized, rest nothing got canalized, है ना? So this explains you the entire concept of bicornuate uterus. In this concept, it is important for you to understand that the cavities will merge here. Cavities will merge here like this, okay? And these fibers, the uterine fibers will continue to go like this. The thing is, the region which is actually the weakest, we say that fundus is a weak region. Why is it that when you are doing classical cesarean section, people want you to do lower segment cesarean section? The reason is, in the lower segment, the ability to contract is very limited. Otherwise, in the classical cesarean section, what happens is, see, something classical, when they see something like this becomes the fundus, forms endometrial cavity, muscle here. Some of the muscle comes here, is present in the close to the, as a result of which when you do a to the stretch, due to the outward stretch and due to contract, this becomes your weak point. You have to understand this is the reason why you have a bicornuate uterus which can cause preterm labors. Okay, you have a bicornuate cause second trimester abortions. The uterus, because this part is really very weak for this uterus. Okay, this is the thing which you need to understand in non-obstructive anomalies, that this second trimester loss is common. As look at a unique cornuate uterus which is like this half of that unicornuate uterus has never been able to get this other half in order to unite, develop its strength, as a result of which the same problems will occur in bicornuate uterus, also occur in a unicornuate uterus. These guys also are accompanied with preterm labor. They also have second trimester losses, okay, and they also have little compromised pregnancy outcomes. It is simply due to the method in which structures get realigned at the time of differential absorption. The simplest of the anomaly out of all these guys is obviously going to be your septate uterus, because septate uterus, what has happened? You have got a broad fundus. It was supposed to get absorbed completely. Okay, but you know what? Majority of the muscle got absorbed and some fibrous part only remained, which gives rise to the formation of fibrous septum. In some cases, that doesn't happen. The muscle also remained. Along with the fibrous part, the muscular part also remained. It gives rise to the formation of muscular septum. And this is the reason why there is a controversy between just resection, okay, between hysteroscopic septal resection and hysteroscopic septal excision. When the component of muscular component becomes thicker, and always remember, where is the muscular component thick? Muscular component is thick close to the fundus. Why? Because the differential canalization keeps on going up, thoda part chut gaya, and that gives rise to the formation of fibrous and muscular septum. If you simply go and resect and cut it open, as a result of which everybody would recommend to place some adhesion barrier between the two walls, okay, because when there is a muscular part, the muscular part can again reform adhesions, okay. As a result of which you need to keep an adhesion barrier. Commonest which people use is by placing something called as a Foley's bulb inside after they have completed the hysteroscopic excision or hysteroscopic resection, and they allow the patient to have lateral epithelialization from the rest of the endometrial cavity, heal itself so that it does not occur. But remember, friends, in that situation also the fundus stays broad. Why does this fundus stay broad? The fundus has no role to stay broad, isn't it? That is because the fundus is broad because that final step of differential absorption and canalization which was supposed to occur did not occur at the level of the fundus, and because it did not occur at the level of the fundus, you have a broad fundus. All right, and the least and the most common which we see is everything has got absorbed. Actually, everything became beautiful only inside. Only a small part did not, and that gives rise to the formation of something called as a arcuate uterus. Okay, where only a small thing, which some people may call as a partial septum or something like that, that remains. Rest everything is completely done. These are your non-obstructive anomalies as far as the uterus is concerned. These non-obstructive anomalies are absolutely fantastic. Okay, they are fantastic because they are going to give the patient an excellent outcome the minute some amount of correction is done. They give an excellent outcome even if some amount of correction is not done for the patient. All right, that there are so many patients with bicornuate uterus who have a healthy pregnancy. Okay, Shilpa madam, can you hear me?
Yes, yes.
Okay, so there are so many patients with a bicornuate uterus who have an excellent pregnancy outcome. So many patients with an arcuate uterus who don't require any correction. Partial septum does not require any correction. There are so many patients who have become pregnant in the presence of a septate uterus. Only then you realize that it was a septate uterus. Same thing is with unicornuate uterus. People are often pregnant and then they realize that the pregnancy has happened. So remember one thing, because there is no obstruction, the process of pregnancy is easy, because there is nothing which goes wrong in the fallopian tube and the ovaries in majority of the situations, as a result of which fertility outcomes are superb as far as non-obstructive anomalies are concerned. Okay, now after I finish this non-obstructive anomalies, the other non-obstructive anomalies is obviously the imperforate hymen. Okay, this imperforate hymen again has got excellent outcomes. If the imperforation is at the junction between the vagina and the cloacal region, then it is a transverse septum. Okay, we have discussed this many times. Then it is a transverse septum. Here it is an imperforate hymen, and both these guys are going to give you excellent pregnancy outcomes, because here is the presence of the cervix, who will allow for the entire hematocolpos to get collected here, and nothing will go inside the endometrial cavity, and the patient will have an excellent outcome once it is completely, the word here which I am going to use is completely excised. As a result of which, in imperforate hymen as well, you are supposed to take a cruciate incision. Transverse septum, you are supposed to take a block incision, and the whole septum should be excised. Imperforate hymen, take a cruciate excision and ensure that they are tied to the labia, so that what happens, labia minora, so that what happens is that the hymen never gets sealed back again. All right. Please remember, we have already discussed in these sessions, you are supposed to rule out something called as mid-vaginal atresia. That is something which is critically important and you need to rule it out. All right. Also remember one more thing. Now you may have certain conditions where you will have to actually practice fertility in these patients. And people will say that, what do I do in cases of bicornuate uterus? In which horn do I transfer the embryo? Do I transfer it in the right horn, or do I transfer it in the left horn? The answer is simple. You should calculate the endometrial volume on 3D, and the cavity which has a larger endometrial volume is the cavity in which the embryo transfer has to occur. This is a simple 3D volumetric calculation, easily accessible by most of our radiologists, by our friends who are trained into it, and it is extremely easy to then go ahead and perform the embryo transfer in the bicornuate uterus, just in case you have to perform it. All right. With this 10-12 minutes, almost all the practical points which one has to clear as far as obstructive anomalies are completely cleared. As far as non-obstructive anomalies are concerned, are completely cleared. I also wanted to mention one non-obstructive anomaly which actually does not require any fertility service at all, and that is uterine didelphys. Okay, that is because uterine didelphys is one particular region where the uterine musculature is formed beautifully. And because the uterine musculature is formed beautifully, the patient has an excellent pregnancy outcome. The patient has got nothing to do with anything else. Okay, but though it is a uterine anomaly, it is to be treated simply as a double uterus and not as an anomaly. Okay, which is why I did not draw the diagram of that and explain. With this, I think I conclude all the non-obstructive anomalies, and I can probably answer one or two questions.
So what is your take on this unification surgery in bicornate uterus?
It is good when the volume of the cavity is very low.
Oh, okay. So, but how do you calculate? Like you calculate
3D on 3D, you can easily calculate the volume of both the cavities, madam. And now what has happened is with Stratafix, no, you can just take an incision and just combine the cavities. It's super easy. I mean, it's third poster level surgery.
like a DNC, you mean? Sure. Yeah, fine. So, when you put the Foley's bulb, so you will keep it for how long? 3 days,
See,
5.
the answer is actually 24 hours is more than enough. If you keep it more than 24 hours, there may be some avascular necrosis of the endometrium of that particular patch. But see, people practically keep it for 3 days. Somebody keeps it for 7 days. It's really up to them. Okay, the standard recommendation is between 24 to 48 hours is more than enough.
And when do you put a stitch inside the cavity to fix that bulb? I have seen you do it in one case. I mean, when do
No,
you
no,
do?
no, no. We do it. We do it. We are doing it in cases where we are doing complete cervico-vaginal reconstruction and only the uterus is there. So that is an obstructive anomalies, madam. You are supposed to take a silicone stitch at the posterior uterine wall so that that bulb never falls out.
So why did
See, when you put a Foley's bulb inside the uterus, you should remember, madam, it is going in the endometrium through a pre-canalized tract. Understanding? Epithelialization inside an endothelium is very easy because basal endometrium is present. When you are treating vaginal reconstruction, what are you trying to epithelialize? You are trying to epithelialize the peritoneum covering the rectum into the uterine muscle. So that uterine muscle peritonealization takes some time, which is why you need that silicone bulb to stick inside, keeping that canal open. And when it has to keep that canal open, you need to keep it inside for a long period of time. Otherwise, the biggest thing which you'll see is you'll do a sexy surgery. Okay. And as soon as you go out of the OT, the silicone bulb will also come out of the uterus. Okay. And then you will be in trouble. That why did you leave the OT? Had you been in the OT, silicone bulb would have stayed inside. So in order,
sorry.
it's a fact. Really. As soon as the surgeon goes, the bulb also goes. Understanding? So better option is to take a stitch through it. Completely take a stitch through it. Okay, it will never come down. Even if you hang on it, it will not fall down then. Then what will happen is after 2-3 months, there will be lysis of that stitch which will occur. And then the silicone bulb will come out. By that time, canalization would be complete and it will help the patient.
Uh, okay, so why did you stop doing the interseed after the septal excision? In a few cases, initially I saw you doing it.
Yeah. No. Actually, we are still doing it on and off. Okay, the reason why we stopped it no is because interseed it causes that little dirty brown discharge after 3-4 days. So you have to warn the patient about it. Second, I had thought that if you just put interseed inside, there will be no avascular necrosis and separation will also be maintained. Okay, we realized that when we cut down our Foley's bulb time to less than 48 hours, no, less than 3 days, ऐसे पकड़ के चलो. In that situation, there is no problem of avascular necrosis. So we switched back to Foley's bulb. It's very much more cost effective, no?
Yeah, I agree on that. And do you put them on estrogen, progesterone post?
12 hours after surgery, next day of surgery.
And this goes on for 2 months, 3 months, and then
Yeah, 2 months is okay.
so in uterus diadelphys, when do you think, I mean, Mullerian anomaly per se is not a reason for us to treat for fertility, isn't it? I mean, do you see any associated factors like more commonly in?
All Mullerian anomalies will have low AMH.
Yeah.
Almost all. I'm not saying all, but almost all. Today we did one. Only today. We got a Mullerian anomaly referred from this one, Quebec in Canada. Okay. It is a Canadian lady. They have shifted from Canada to Bombay. Okay. She is unicornuate uterus, previous rupture. They have repaired it. Okay. And now they've sent to Bombay for doing embryo transfer and IVF and everything. She's doing fresh transfer this month.
So how is it different? Like, I mean, is it the same, like where you just go ahead and do the embryo transfer? Do you take any extra precautions in these cases? Like you give uterine relaxants, do you give
But I'll tell you one comedy thing what happens in uterine anomalies. Nurse will be showing one horn of the uterus, you will be transferring in the other horn of the uterus. Okay, that is very common. Everybody will be searching the embryo. Unless you are doing embryo transfers like me, when we don't do the ultrasound only. So nobody knows. But otherwise, I've seen people who have called me, hey, bicornuate uterus embryo is not being seen. Only we have to right on pe dikhao bas. Ask the nurse to. Nurse is very rigid. No, you ask them to hold in the center of the uterus full life, they will keep on holding in the center only. They will not understand bicornuate uterus. They will not go right, left. They will not even allow you to go right and left. Somebody has to video call and tell them, "Arey, meri maa thoda right pe ja." And that's a very common problem in bicornuate uterus. Only in bicornuate, because bicornuate is one part where that musculature has not been able to join to each other. No. So because of the pelvic traction, both one is on one pelvic wall, another is on another pelvic wall. Okay. In all other situations, didelphys and everything, it is in the center. So
yeah, so we see the septate uterus with multiple abortions, and then
yeah.
suddenly they have a live birth, like, without any problems at 34, 35 weeks. So how do you explain, like, I mean, is it by placentation which is happening at the septum and then there is no idea?
I don't know.
So
All these bicornuate uterus, another thing which I have noticed. I mean, I don't know. I don't know if it is actually true also. Okay, but I have noticed that majority of the times when we have delivered this bicornuate uterus, unicornuate uterus, no, pregnancy is in breech position also in the time of delivery. Okay, this is what we have noticed very commonly. Understanding?
That's textbook like long back. This is not like some invention. This is a common thing. That's because the fundus is broad, which will accommodate the broader part of the fetus, which is the head. Okay, so that is why you should know obstetrics. You cannot be doing stratafix suturing for cesarean section and not know this. It's okay. I know your level or your range is that much only. It's okay. Okay, sorry to get distracted. One more thing I wanted to ask, I forgot. Okay, so in your cases, because you do so many Mullerian anomaly surgeries, and of course, because they are associated with low AMH, so majority would be getting the treatment also with you.
Yeah.
So in these situations, what are the common things that you have come across, like, like problems in probably like conceiving with IUI or in IVF? I mean, what are the common things that you come across, and also the success rate? I mean, do you see that these anomalies generally have a lesser success rate or they are equal compared to
No, same. Success rate is same. Only problem is low AMH.
Okay. So you do multiple
And
stimulations?
one more thing I will tell you one more thing. Many times you will have ovary which is highly placed.
Yeah.
Okay. In Mullerian anomalies, both obstructive, non-obstructive. So in that situation, I think doing laparoscopic pickup is a very much good thing. Okay. What? It is a good thing.
So in a month, how many do you do? Like in the recent past?
See, on a year, we will be doing around 12, 13. Not more than that.
Okay. So the same way that you showed in your live surgery from Hyderabad, that
Yeah.
it's the same thing?
Same to them. Nothing doing. Just stabilize it and just pick up. Bindas.
Okay. Yeah. Thank you. So people are referring for laparoscopic oocyte pickup to me, even in normal cases now, because you have showed it. Okay. But thank you. Thank you so much for enlightening all of us.
Thank you, madam.